Okay, perfect. I will kick us off then. Thank you everyone so much for joining today. Just wanted, before I hand it over to Dr. Mizik, to go through some of our CME requirements. So you'll be receiving an email from Lifa, our admin assistant, that has all of this same information as well. So don't worry if you don't get it on the slides. We'll send out the slides too. To get CME credit, you're going to text 71200 to the number on this screen. This will send you a direct link to fill out the evaluation. If you miss sending this text, though, you're still able to complete the evaluation on the Beaumont CME site, which is listed here and will be included in the handout that we send as well. We're offering continuing education credits for nursing, pharmacy, dietetic CPU, as well as medicine CME. And for our disclosures, Dr. Ashman, who is our program director and of course co-director of stocks and publicly traded companies. The last thing I wanted to let everyone know about is we're doing a sign-in sheet for these meetings because it's been challenging for our team to be able to match up what people's Zoom names and attendance are with people participating in the collaborative. So only if you are a physician who wants to earn learning community credit for attending do you need to sign in. If you're not, you will not need to. In the follow-up email that we'll send after the meeting, we will make sure that you have this link, and then just make sure your Zoom name matches what it says on Zoom so that we can adequately match it. And we'll include the instructions on that follow-up as well. I'll put the link in the chat shortly so you can sign in now too, but you will also have the opportunity to post-meeting. And so with that, I am honored to introduce Dr. Brianna Mezek, who is a professor of epidemiology at the University of Michigan School of Public Health. Her program of research examines the intersections of mental and physical health in mid to late life, including the relationship between depression and diabetes. She's currently directing the Diabetes and Mental Health Initiative at University of Michigan, which is funded by the Caswell Diabetes Institute, which is a mixed methods project aimed at improving person-centered diabetes care at Michigan Medicine. So we're very lucky to have her here today to cover some of the psychosocial aspects of diabetes care and to learn from her experience. And with that, I will turn it over to you, Dr. Mezek.
Thank you so much, Jacqueline. So thanks everyone again for this warm introduction. It's an honor for me to be able to talk with you today, and I hope that we have a helpful conversation. To begin with, I wanted to just acknowledge I have no conflicts of interest, financial or otherwise, to disclose, and I wanted to thank the people on my team here. None of the work I'm going to show you today really would be possible without their experience and expertise. The other thing I'd like to sort of start off with before we do some Zoom questions to sort of kind of just help us all kind of get a better sense of understanding of where people are when it comes to addressing psychosocial needs or mental health needs of people with diabetes, is I want to sort of emphasize what my positionality is in relation to sort of the work I'm going to show you. So I'm a researcher. My PhD is in psychiatric epidemiology from Johns Hopkins. I'm not a clinician. And so what that means is that I see my job as trying to close the translation gap from bench, of course my bench is this office, I don't actually have a bench, right, but to bedside, that is into clinical care. Part of the reason why this is why somebody like me, that is somebody who sort of studies more psychosocial aspects of health, with the role I have in there is illustrated, I think, here by this article that Mary DeGroot wrote. This is a summary of a talk that you can see from the date is 2020. So we were all at home. There was not actually a ADA meeting that year, but what she calls out in her speech here is that the behavior is fundamental to everything we do. So even though there are always going to be a new drug, a new hot technology, a new hot app, whatever it is, that it doesn't matter if people don't use it. And that means having an understanding of behavior and how that relates to diabetes care. As Jacqueline mentioned, I'm here at the University of Michigan. We've been doing a project that is trying to understand what are the mental health needs and how do those relate to other aspects of people's lives here at Michigan Medicine. I'm going to show you a little bit of data from here, but I guess I want to, again, emphasize that my clinical experience is frankly being a patient. And so that I think I hope I can learn from our conversation today is what is it like to be on your end of that patient-provider relationship, and ways that the research that I'm going to show you today can inform help you be the type of clinician that is able to engage in the person-centered care. So with that in mind, the three things I hope you're going to get out of this session today is a greater understanding of the connections between mental health and type 2 diabetes and the implications of those connections for clinical outcomes. Some tools and strategies that you can, as an individual provider and as an individual practice, use to better address psychosocial aspects of diabetes. And finally, resources for implementing best practices in person-centered diabetes care within the larger collaborative that you all are engaging in, which I think is a really wonderful, wonderful thing. So with that preamble, I'd like, Jacqueline, if we could do our first Zoom question.
Okay, it should be up for everyone now. And I think you should be able to see the responses as they're coming in too, Dr. Mezek.
I guess I have to answer it myself.
Okay, once I end the poll and share it, you'll be able to see everyone's.
Oh, okay, good. Thanks.
We'll give people just a few more minutes or seconds because some of the answers are still coming in. I'm going to go ahead and end the poll and share the results for everyone to see.
All right. So this is we describe this as a kind of a bimodal distribution in my work, that about maybe a third of people do this every single time they see their patients, or even maybe a little bit often, because obviously your patient's not going to, sometimes your patients might come every 6 months or every year. But then for other people, only when there's sort of a clinical or some other indication that suggests that this would happen, and then a minority of people don't typically do this. So that's good to see that most people are doing some sort of assessment, whether that's prompted by something that the patient is experiencing or not. Could we do the second question now, please?
Yep, give me just 1 second, getting it pulled up.
Thank you. We'll do the other two later. This will be the first two we'll do at the top.
Okay, everyone should be seeing the poll now. Based on your clinical experience, approximately what proportion of patients do you think experience substantial diabetes-related distress? Okay, I'm going to go ahead and stop and share the results with everyone.
All right, so this is wonderful to see this, that especially that, again, I think that the fact that nobody said less than 10% or I don't know means that you see this a lot in your clinical practice. So what we see on average is about a third of people have clinically significant impairment. So if your patient kind of population is substantially higher than that, which it looks like about a third of you experience a substantially higher proportion of that, I think there's some things that I'm going to share with you today that can hopefully help manage that, because certainly there's a high need for such management. Thank you, Jacqueline. So I want to just give a little bit of background about what we know about the science of the relationship between mental health, or depression in particular, and type 2 diabetes. I want to just make sure we're all on the same page, because as general practitioners, I know that you are the front line for treating depression. That is, most people don't see a mental health professional, but rather if they see anybody, it's you. And this is a condition that is not just feeling sad, but is about feeling disinterested, not being able to engage in avolition, not having motivation, fatigue, sleeping problems are a very core problem of this, trouble concentrating, and suicidal ideation. And the World Health Organization has said that depression is the most common and the most impairing health condition. I don't mean mental health condition, I mean health condition in the entire world. So in terms of like the number of disability adjusted life years lost. Now that's a lot of words, but if you've never had a depressive episode, let me use this illustration. This is from Ali Brosh's memoir about her experience with depression that sort of illustrates ideas around avolition, anhedonia, and suicidal ideation, sort of how people might sort of literally experience this in their day-to-day lives. Depression incredibly common. 1 in 5 Americans will experience a depressive episode at least once, and half of those people will have more than one episode. Most of this will begin early in life, and it is more common among women and people with lower socioeconomic status. And again, I imagine that this is probably consistent with the cases of depression that you observe in your clinical practice, that people with higher social needs are also more likely to have depression. What's also really important to understand is that most people with depression do not get either timely or minimally adequate treatment for their condition. What that means is that the vast majority of depression cases that you're going to encounter in the world are people who don't have access to adequate psychotherapy, maybe don't have the right kind of combination of pharmacotherapy to support their condition. In fact, only 50% of people with depression in 2023 got anything for their condition. And so I guess I want to emphasize is that there's a lot of ground that we can make up when it comes to managing depression, period. But because, as I'm going to show you, depression and diabetes are strongly correlated, this is even more important for someone as part of management of diabetes care to be thinking about managing depression, which is, I guess, what I just said. Again, that people with diabetes are about twice as likely to have ever experienced a depressive episode. I wanted, of course, we might think like, well, of course, diabetes is kind of a difficult, it is a difficult condition to manage. Of course, maybe it's not surprising that people who have a history of diabetes are more likely to have depression. But what's also important to understand, and this is sort of where the science is currently, is that depression isn't just in the brain. And in fact, we now have a large body of evidence showing that depression is associated with changes in neuroendocrine systems, changes in the immune system, and there's even emerging data that it's associated with changes in gut health and the microbiome, it's not just behavior and it's not just mood, but rather it's really the entire person's physiology that is affected when someone's in a depressive episode. And all of these systems, I'm sure, are implicated either in the prognosis of diabetes or in the risk of developing severe outcomes from it. Now, just because depression might be a cause of diabetes doesn't mean that diabetes can't also cause depression. And why is that? Well, this is, again, because diabetes isn't just in the body. It's not just in the pancreas. And this is a quote from a woman who has type 2 diabetes that was one of my favorites when I kind of talk to people about what help them understand what it's like to live with this condition. And she says, when you feel these emotions, you just want to stop. You don't want to deal with it anymore. It's not a good thing, but you just want to take a break, diabetic break for a day, a week, or a month. And what I love about this quote is the next sentence where she says, your mental health helps you be able to say, I want to be normal on Friday. On Friday, I'm going to go out with my friends, eat what I want to eat, drink what I want to drink. On Saturday, I'll be a diabetic again, but on Friday, that's a diabetic holiday. The reason I show this is because she explicitly ties her need for a mental release from the constancy of managing diabetes to the behaviors that I'm sure that you as a clinician are advising your patients to not engage in. That is, you're advising them to watch what they're eating, don't drink alcohol, don't eat certain foods, et cetera, et cetera. And so she's the fact that she is sort of specifically tying her behaviors to the mental health, that release that she gets from it, which again is not just psychological, but is actually physiological release, is based on what I just showed you, is really important to understand. That these we can't think about depression and diabetes, but rather we should think more about depression as a complication of diabetes. The other, this is sort of just making this point again, that people with diabetes also have alterations in their stress response. So literally the way their bodies respond to stress, if you have diabetes, is different than if you don't have diabetes. So again, not just a psychological experience, depression, but depression is also neurobiological. The other piece of that, setting aside depression, is the importance of diabetes related to stress, which we talked about in our Zoom poll already. So this is a negative emotional state that's again, clearly tied to the experience of managing diabetes. And it includes feelings of anger, worry, avoidance, engaging in unhealthy behaviors like this experience that we just saw, and then also feeling alone and isolated. And of course, there is substantial overlap between people who have elevated depressive symptoms and people who are experiencing diabetes-related distress, but they are not the same thing. And in fact, the interventions that are appropriate for diabetes-related distress are not necessarily the same set of interventions that are appropriate for managing depression. And so helping to, as you sort of, that as you explore sort of where the sources of someone's in distress and impairment are coming from, it's important to kind of keep in mind that not all diabetes-related distress is depression, and not all depression is diabetes-related distress or is due to diabetes. This is what it looks like in Michigan medicine. So that this is, again, indicating we have about, as I told you earlier, about 20% of people have a depressive episode. All of Americans, well, it's a 17% here in Michigan. About half of that have a severe anxiety, and as I said earlier, about a third of people are experiencing elevated diabetes-related distress. This is all types of diabetes, so I guess we'll not emphasize that. It can be different, of course, based on how long you've had the condition and things like this. But overall, this is what we see. And this is just another example of, again, some of our work here from Michigan Medicine that emphasizes the themes that I showed you from that quote earlier. This person saying they get so frustrated, they get so down that they want to give up. That if I'm doing all this work, I'm trying to watch what I'm eating, I'm trying to exercise more, I'm trying to do what my doctor's asking me to do, and my sugar levels are still not where the doctor wants them to be, I might as well just throw it out. I might as well just throw in the towel. It's the idea of having another full-time job. I share all this because I think it helps sort of illustrate just how it's not about not knowing what to do or not wanting to do it, but rather that there are elements of this condition that are not due to a person's behavior, that they are physiologic, right? And so sort of emphasizing that piece of it. The other thing I wanted to just say at the top is that another contributor to diabetes-related distress is the experience of shame and self-stigma that people with diabetes, particularly type 2 diabetes, often feel. This is from a study that came out just last year looking at physicians who treat patients with type 2 diabetes, looking at the endorsement of stigma attitudes. And so what I'm showing you here is the percent of providers who agree with the following statements about their type 2 diabetes patients. And so you can see about 20% of providers, say that they agree with the statement. They feel disgusted when they treat a patient with type 2 diabetes. That if I find it, a third of people say they find it difficult to have empathy towards a patient with type 2 diabetes, or that they ascribe negative personality attributes, or even kind of like moral failings of laziness or lacking willpower to their patients with diabetes. Now, these types of attitudes are the way they're going to be experienced by the patient are, as I mentioned, shame, self-shame, and stigma, which are going to then be associated with avoidance behaviors and further disengagement from the care process. And so I think it's important that we have people here at Michigan who study specifically, and I'm involved in a study I can talk about in the Q&A, where we're actually looking at potential different training modalities that might be able to be supportive to help people sort of be aware of their stigma attitudes and address them. But I think I just want to call this out as something that's also important. Abdul, did you want to comment?
Oh, no, I'm sorry. I just signed on and I'm just
okay.
trying to figure out how to open the video and mic. Sorry
okay.
about that.
No, it's okay. I saw your video come on, so I just wanted to ask. No problem. So the last thing I guess I want to say just by preamble is just emphasizing that even though addressing diabetes-related distress as an outcome in and of itself is important, and even though addressing depression as an outcome in and of itself is important, it's also important for the kind of clinical outcomes that you're trying to work towards when you are engaging in diabetes care. So we know from large longitudinal studies that depression is associated with an increase in HbA1c over time. And I'm not going to show you data on this, but it's also higher A1Cs are also associated with worsening depression over time. So this relationship, which is summarized here, is really bidirectional. What that means for clinical care is that it's not about which of these two problems am I going to try to address today, but rather, how do I take a care approach that addresses both of these problems and it addresses parts of both of these problems at the same time? Because as you can see, you're going to be playing whack-a-mole, and maybe that's how you feel about it with some of your patients. I imagine many of you are thinking about particular patients that might be in this sort of cycle here between depression and diabetes symptoms or diabetes worsening. That how can we have a care model that helps address both of these aspects of their health problems at the same time? So that's what I'm going to turn to with the remainder of my time. And so I'd like, Jacqueline, if you could do the next two Zoom questions, please.
Yep, I will launch them now. So you should all see the question in the chat. It's how confident do you feel in your ability to manage the psychosocial aspects of diabetes, so mental health problems, diabetes distress, burnout with your patients? And 1 through 10 is your options. Okay, I'm going to go ahead and end the poll and share the results.
So this is great to see. So I guess, again, this is not quite a normal distribution, but again, it's clear that there's a lot more that there's a lot to be gained by kind of feeling, more. Some people feel more confident, some people feel less confident, but nobody feels so confident that they could teach others how to do it. And so it's helpful to sort of see where most folks are with that. That's great. Can we do the next question, please?
Yep. And so Dr. Mizik, we weren't able to do this as a word cloud, but everyone will be able to type in a short response answer for this one. So I think everyone, are you able to see it now? Oh, let me see. Can you see this one to respond to?
No, I don't see anything.
Okay, it's not giving me the option to launch it for some reason. It says a poll has been launched in this meeting. What we could do as well, give me one more second to try to launch this one. Oh, I think maybe it's because I didn't stop sharing. Okay. Okay, there we go. Now you should be able to see it. It's what's missing from your practice that could help you more effectively address the psychosocial needs of your patients with diabetes. And you should be able to free text write in a response to that. So we'll give everyone a little bit longer on this one to submit some answers.
Thank you.
Mm-hmm. Okay, we have 20 responses. I'm going to end the poll and then share results. I might have to share my screen for just 1 second to show them to everyone. Give me just a minute. Yep. Okay. I'm going to have to sign in to view details. So give me just a second there.
No
and then we should be able to see the responses. Okay. So I have the screen share loading right now. So I'm going to go ahead and read through some of these. So improved access to mental health providers if patient is needing this level of care of intervention, in-house mental health workers, access to mental health professionals, getting paid for the significant amount of time it takes to do this properly, community health workers and BASW, a social worker, time with the patient to do everything, integrating find help to get more resources for patients. Nothing, thanks to having a fantastic nurse care manager. Better access to PS colorectal services, more detailed diabetes education, more mental health questions, more visit time, screening tools, more frequent diabetic education appointments, more access to nutrition, financial assistance, time, a questionnaire that asks SDOH questions, in-house therapists, greater access to behavioral health therapy in office, educational resources to provide, and social work availability.
Yes, more time. We need Beyonce's team to help us with this. It wouldn't be without her team. So thanks to I'm both I'm not surprised by those results, but I'm going to give you some things that I think can help you both as a provider, as a practice, and then hopefully as a collaborator, because I think you've actually also self-identified some of the things that are going to be really helpful here. So I think I'm resharing my correct screen, Jacqueline, is that right?
We can see everything perfectly.
Thank you. So what does this mean for clinical care? So as I said earlier, what we need is to really embrace a model of care that addresses both mental and physical health aspects of care in the same setting. That this is not, so while we need behavioral expertise to bring in to different parts of care, and certainly sometimes we need to refer out, but there's also care models, right? Like of course, that patient-centered care, which you all are I know, striving to in your practice. But it's very difficult, of course, when patients have really complex needs to engage in that. So I want to leave you with 3 different sort of levels of what you can do. So the first is, what can you do as just one person, as just one provider, to address psychosocial care, better address psychosocial care needs of patients with diabetes. So before I kind of tell you the answer, I want to tell you what patients here at Michigan Medicine say. Like, what do they wish? So we ask people to finish the sentence. What do you wish your doctor did more of? And what do you wish your doctor did less of? And so when people say what they wish their doctor did more of, they wish they were more empathetic, understanding, supportive, friendly, open-minded, recognizing my challenges. And sometimes, of course, people say, no, my doctor's great. There's nothing I wish they would do more of, right? They're doing a great job. What do they wish their doctor was less of? And I think this sort of reflects some of the things that we talked about earlier with diabetes related to stress and the shame, the self-stigma that people with diabetes often feel. The idea that they're hurt, that they're judgmental, that they feel harping and critical and pushy, so there's things and I can imagine that if those are the emotions that a patient's feeling about their doctor when it comes to their diabetes care, it's going to make it very hard for them to have the kind of approach-oriented or kind of motivational things to engage in, the types of behaviors that you're asking them to engage in. And so let me help you. What I want to leave you with, again, are some things that you as a provider can do to help address some of the things that we've talked about and what these patients are talking about. So the first is that you need to talk to your patients about the emotional side of their diabetes. And I think framing it that way, the emotional side of diabetes, is a way to engage some patients in a conversation that they otherwise wouldn't really want to engage with you with, because depression and anxiety are still highly stigmatized, particularly in certain populations. And so rather than say, oh, you might have depression, which is a word that your patient may never use when talking to you about their emotional health, say, I'd like to talk to you about the emotional side of having diabetes, right? And the toolkit, which is hyperlinked here, is the ADA Behavioral Health Toolkit. They have very specific worksheets for you to give to your patients as an example of like, how do you adjust with life with diabetes? It's not 500 pages. It's not like the Standards of Diabetes Care, which I know is this thick. It's 12 pages, okay? So it includes the PAID, the GAD-7, the PHQ-9, and also how to actually, like, here are educational materials and fact sheets that not just you as a provider, but your kind of broader, your nurses, your paraprofessionals, all the other people in your practice can have an understanding of, like, what does this even mean? Because the reason I defined depression at the beginning of our talk today is because that doesn't mean the same thing to every person, right? And so it's important to kind of get everybody on the same page. So my first piece of advice is to ask people about the emotional side of their diabetes. Now, that's a one person. What can you as a practice do to better address these needs? So within your individual practice, which I know are spread all over the state of Michigan. So my advice here is to train your entire staff, your entire clinic, on what the 7A model of diabetes and emotional health, which is again provided here in the American Diabetes Association. I'm going to tell you exactly what this means in a second, but I want to emphasize that this isn't just your job. That is your job as a physician or as a nurse practitioner, whoever kind of the primary person that the patient is seeing, but rather everyone within the practice has a responsibility or has a role in the 7A model. So the 7A model includes our 7As, right, which are awareness, which is understanding that's what today is. What is psychosocial, what is the emotional side of diabetes, right? So you can check that box. Asking about it. And again, the toolkit that I provide that you're going to get, which is the first thing I said, is like, these are the tools that are evidence-based that are appropriate for asking your patients about the emotional side of their diabetes and assessing it, again, using these standardized questionnaires. Advising on sort of what is the most distressing part and sort of how do they manage that part of the distress, biting off, like figuring out what is the part we're going to bite off and work on at this visit or in the next 3 months or whatever it's going to be. I understand you don't always, in fact, most of you don't have, but I know that the mental health workforce does not exist. The behavioral health workforce that you need does not exist, and there is no future in which it does exist. There's no future in which there are enough behavioral health providers out there, no matter what we do. And so what that means is that, and I'm going to, so don't get depressed, but like what it means is that we have to think about, okay, well, what are the other types of specialists or kind of people that we can bring into the conversation, whether that's, is there a shared a social worker for the entire practice? Is this about support groups that exist already that are run maybe by a church or some other type of group? Again, I'll show you in a second, but the notion that this is on your radar, that the patient knows that this is on your radar, and that is going to go, and that the practice as a whole is centering this idea of this emotional side of diabetes as the way that they approach, oh, excuse me, I should have clicked that up, that the patient as a whole has, this is something that's going to be talked about, not just when they're struggling, but really during all their visits. You're going to check in on people, because it's also nice to know what people are doing well and asking and making sure that you know that what's been going well. How have we turned that corner here? I also want to call attention to, as a practice, an incredible resource that we're fortunate here to have in the state of Michigan, which is this Peers for Progress. Peers for Progress is, can I ask, I don't know if people can show hands, how many of you have ever heard of this organization? Maybe you could throw in the chat if you have. I'm going to assume nobody has them. Okay, good. I've changed your life. That's wonderful. So Peers for Progress is an organization. This is a partnership between the University of Michigan and the University of North Carolina. And what it has is all of the training materials you could ever need for starting a diabetes peer support program. There have been multiple randomized control trials showing that being a peer supporter and then being part of a diabetes peer support program are both associated with improvements in depressive symptoms and improvements in hemoglobin A1C and all of the other things that so this is not about you sort of relinquishing the care that needs to happen here, but rather this is an augmentation that has been shown that you don't need a PhD, you don't need to be a clinical psychologist or a psychiatrist or even a social worker to engage in this kind of care. And in fact, to engage in peer support. Oops, sorry, that's clicking out there. So I want to call it so some of the work that I've done previously is with the YMCA. So not all YMCA programs have a diabetes control program, but the ones that do, these are run by people who were the peers that are in these programs are just people who kind of have been through a day training on how do you talk to people about diabetes. These are not certified diabetes educators. These are not experts, but rather what they have is either lived experience with the condition, and then they've been, or they have an interest in being sort of like more of like a coach type model. And what I'm showing you here is data where we analyzed people, I think, yeah, almost 300 people with type 2 diabetes. And this intervention, again, which is not provided by a behavioral health specialist, had dramatic improvements in depression, which is panel C here, also dramatic improvements in A1C, and an increase in frequency of checking blood sugar, right, which is kind of our metric of engaging in care, being willing to look at whatever your numbers are, even if the numbers aren't good, right? Because I think that's part of what we kind of need to, the emotional part of engaging in that diabetes care. So I want to encourage you, and this is something that as a clinic, or frankly, also as a collaborative, as a network of clinics, you could consider doing. There are models that have been doing this online. Of course, we have to be very conscious of the digital divide because not everyone has access to the kind of high-speed internet that we're using right now. But I want to sort of let you know, you do not need expertise in order to launch a peer support program. In fact, that's part of the value, is that, and I can tell you, when people in this program, we ask them, like, how is being in this program different than talking to your doctor? And the specific thing they talk about is like, my peers don't judge me in the way that my doctor might judge me. And I don't mean that in a negative way, in the sense of like, it's part of your job. Part of your job is to let patients know when they're on track or when they're not on track. But when hearing it from a peer is different. We all have this. There are all people in our own lives where it's the same information, but coming from a different, the messenger matters, I guess is what I would like to say there. So the last few things I want to close with before we get to the Q&A are, what can you as this broader network do to better address psychosocial needs of patients with diabetes? And again, I've already, even though I put this sort of advice on developing a peer support program under what you can do as a clinic, it can also be something that you could explore doing as a collaborative. So the best evidence, and by this I mean literally probably 15 to 20 randomized controlled trials on how do you address situations of patients with diabetes and depression, which I'm going to kind of collectively refer to as somebody with a complex health needs, is implementing the collaborative care model. The collaborative care model is not, this phrase that has maybe been used in many different things, but I mean it to mean a very specific thing, which is illustrated by this graphic here, where the patient is at the center, you, the primary care provider, are at the top of this triangle. There's some sort of consultants that maybe you, again, have contact with, and then there's this behavioral health care manager. Now, I understand all of you identified this is what you need as part of your, that would help you address this. And I understand that takes money, right? So I think that's part of, then it's a different kind of conversation. It's not about like, what do I need? It's like, how do we make it happen, right? Again, I won't belabor this, but if implementing such a care model, implementing the collaborative care model, which, I'm sorry, I'll go back here. The AIMS Center here at the University of Washington, this is all they do. This is all they do is teach clinics how to implement the collaborative care model. I'm going to show you, call out a couple of specific resources for them in a minute, but I just want to say, like, this is not something that you build from scratch, but this is something that you build through a connection with them. So again, multiple meta-analyses have shown that if you have someone with both type 2 diabetes and depression, so exactly the type of patient that we've been talking about today, that the collaborative care relative to usual care is associated with improved depressive symptoms. These are like a standard difference of 0.32. That's like a third of a reduction of depressive symptoms of about a third. Also improved glycemic control, again, improvements in about a third. And you might say, well, my patients don't just have depression and diabetes. They've also got high blood pressure and all these other problems. Yes, I know they're complex. And this model also is associated with improvements in A1C and blood pressure among people who have comorbid depression and diabetes. Really substantial impacts here, particularly for systolic blood pressure here, where you've got, a 0.6 standard mean difference, right? So vastly, not just statistically significant, but very, very clinically significant improvements. So, okay, Bree, I'm sold. How would I do it? So So this is an investment. This is something that you turn on like a faucet, right? This is something that as a collective, you could sort of say like, this is, you all have the same problem. You all have patients that have unmet psychosocial care needs, and you don't have 24 hours, you don't have more than 24 hours a day to do this, and you don't have Beyonce's team, right? So this is something where, again, as a collaborative, working with the AIM Center, explaining where the asset map that you have is, and then also what are the opportunities and where you need to grow. This is, again, I want to encourage, this is all they're designed to do. This is a screenshot from their website of how would I get started? How do I bill for this model, et cetera, right? They have thought through all of the questions that you're going to have for how to implement such a model. I want to call attention to two specific trainings that they offer. The first is free training for primary care providers on the collaborative care model. It offers 2 hours of CME credits. So now you can apply for CME credits here, but I want to encourage you also to attend their webinars, which you can also do for additional CME credits, as a way to really understand how would your practice change if you were to implement this model, and what problems would that solve for you, and what new challenges might it introduce for you, right? And this could be something that you could also, again, explore with your broader, everyone at your practice, everybody from your billing folks to your administrative support to your nurses. Money is, the more I do this work, the more I realize like everything comes down to money, like how much is it going to cost? So I also want to emphasize that they have webinars for how different healthcare systems, because of course we're not all group health. In fact, none of us right now on this call are group health, which is what they have out at UW, but how you might bill for the types of things that go into the collaborative care model. And so again, I want to call attention to resources that they have here. I'm not a health services expert, and so I want to again emphasize that they are experts in implementing this model, and they have thought about, again, many of the challenges that you'd face. And then I mentioned, of course, money, right? Money is a big reason why in addition to the behavioral health workforce just doesn't exist, right? It's not large enough to address all these needs. But the collaborative care model is also cost effective. So what this is from, again, a study published just this year from data that was taken in 2015. So looking at overall costs of patients are lower, especially costs related to hospital rooms and urgent care and emergency room visits, which is the final bar down here. So yes, by having a collaborative care model, you can see, notice like the diagnostic costs go up. Well, of course, that's because they're getting to a social worker, or maybe they're getting to a nutritionist. Those are the types of things that you're looking for your patients to get to so they can live better with their diabetes. But when that stuff starts happening, people don't end up in the emergency room as often. They don't end up in urgent care. And so not only does it reduce costs, but the emotional, again, aspect of living with this condition is better addressed, which is what I showed you earlier. So I think this is my penultimate slide, which is that there are, again, three things, the three different levels of approaching this problem of this emotional side of diabetes, or addressing psychosocial needs of your patients with diabetes. The first are things that individual providers can do, which is my advice here is to ask patients about the emotional side of their diabetes, and even use that specific phrasing so they can kind of enter into a conversation with you that they might otherwise not be willing to enter into, because depression, again, is still very highly stigmatized. As individual practices, that you can work on implementing strategies that are meaningful given the resources that you have within your clinical practice for screening, referring, if possible, or addressing psychosocial aspects of diabetes across your practice. Again, and this would also include supporting a peer support program for your patients with diabetes, figuring out how would you actually partner maybe with your local YMCA, partner with a church that maybe has a health ministry or medical ministry, these types of other types of partners that you can engage with for your patients with diabetes. And then finally, as a collective network, because this is something that is beyond the scope of any one provider being able to do, is saying like, this is a priority for us. Like, we would like to figure out how do we implement the collaborative care model, again, specifically as it relates to the model I showed you earlier, that's developed by the University of Washington. How do we make that happen here? Because the fact that you're a collaborative and the fact that we, thankfully have things like telehealth now means that you could share, for example, a social worker among many practices. It's not that every patient, every one of your patients with diabetes needs the collaborative care model. Your patients that have poorly controlled A1C or poorly controlled diabetes related to stress, like those are the people that you would kind of start with, right, to kind of engage with this model. So how would it look like? What would it look like? And how, again, what challenges, new challenges would it present? But also what problems would it solve? And this is the last slide I'll leave you with. So I share this because especially for those of you who are physicians, I'm sure you've sort of, as part of your medical training, learned something about Thomas Willis, who's obviously one of the founders of the field of physiology. And I love this quote because it sort of illustrates how there are no new ideas under the sun. So even though in the last 20 years, we've actually been able to, we finally have data to test the question empirically, what is the relationship between depression and diabetes? Thomas Willis in 1679 already knew that there was an intricate relationship between the two. And he wrote here that he said that the disease of diabetes could be caused by, immoderate behaviors, right? So drinking a little bit too much, right? But also periods of sadness and long grief and depressions of the animal spirits, right? So the fact that with this idea, this is the depression and diabetes, of course, diabetes related stress. This wasn't even an idea back when he's writing this, but the idea that depression is a intricate part of the experience of having diabetes that is a very old idea that is central to the experience of living with this condition, and so it needs to be central to our care experience of providing person-centered care. And with that, I have left some time for questions, and I appreciate your attention and your feedback. And I'll stop sharing. Thank you.
Thank you, Dr. Meslick. I also wanted to say just before we jump into questions too, that one of our collaborative members reached out earlier this week, Andrew Kareka at Medical Network One, and he was telling me that they'd started working with a group called Janus Healthcare Partners that offers a turnkey approach to the collaborative care model care, and they provide access to a social worker and a psychiatrist, and they said that they're implementing it. They've been an absolutely wonderful resource and great to work with so far. So if you are interested in exploring the collaborative care model a bit more, Andrew said that you could reach out to him and he'd be willing to share like how his PO's experience with Janus has been. So I will put his email in the chat in case anyone is interested. And then yes, please jump in with your questions or type them in the chat.
I'm curious as to whether the sort of reaction that if there were the data any of the data I showed you on the patient side of living with diabetes were surprising, or is that very consistent with your clinical experience?
Y'all can feel free to put your responses in the chat as well if you're not comfortable unmuting and answering. Okay, do we want to do a last call for any questions, any maybe, patient examples of things that you've had come up that you weren't sure how to handle, or any particular aspects of addressing diabetes distress?
Thank you for sharing, Roberta. I think sort of I think understanding how normal it is, that how common it is also when I talk to people with diabetes, they often don't know that it is very normal to have a lot of distress about their condition, and that, you know, look, I have a history of cancer. Okay. So we have a whole field, there's a whole field of psycho-oncology just about the emotional aspects of adjusting to a diagnosis of cancer. There's nothing like that for diabetes. So that is, we're not as explicit about it, is what I should say. I shouldn't say when there's nothing about it, there's nothing like it. It's, we're not as explicit about it. And so I think moving towards this is important. Stephanie, to your question, I would say I would do both. They're not the same. So someone might have depression. So certainly, for example, the PHQ-9 will assess something like suicidal ideation, which is not something that's going to be addressed in the PAID. And so, which is your measure of diabetes related distress. So I would do both. They're going to be correlated, of course, but somebody might be having a depression because they're going through a divorce, or there's something happening with their kids at home, or there's something happening at work, and it's affecting their ability to manage their diabetes, but they're not upset about their diabetes. It's not, it's, you know, so they are distinct, and that would really help you then sort of distinguish, okay, is this something, if a person's dealing with a depression, is there, you know, is this around counseling or getting them to a counselor around the depression, versus if it's diabetes related distress, well, okay, let's talk about how we're managing your diabetes, right? Or maybe that's maybe that's more of like what a peer supporter could help with, versus a peer supporter is probably not going to be as able to help with somebody who's dealing with a depression that's unrelated to their health conditions. What I found is it also, talking about sort of naming that it's very normal to experience negative emotions, is often a way to open the door for a conversation. I'm not saying that's an easy conversation, but the way I think about it, your patients have are dealing with these emotions whether or not they're telling you about them, right? And so by being sort of having this as asking as part of the experience, I think, of the patient experience, and not just when they're struggling, but always, I should say always when they're struggling, but not just when they're struggling, helps normalize the experience, and helps kind of, because of course we've all been in the situation when you're very, once you're in a depression, it's very hard. And some of the symptoms of depression are not being able to, not having motivation. Like, that is a symptom of depression. It's not a consequence of depression. It's part of the health condition, so being able to sort of engage with the conversation ahead of time, before a complication develops, or before, you know, maybe there's a comorbidity that gets diagnosed, and sort of having that relationship, I think, would be very supportive and helpful.
Dr. Mizik, are you okay with us sharing your slides with the collaborative
Absolutely.
following the presentation?
Yes, absolutely.
Fantastic.
I've linked out almost every one of these slides as a hyperlink out to a specific resource that I've provided, or the specific, you know, so I know you don't have time or potentially even interest in reading some of the research that is behind what I showed you, but it's also linked there. So again, I encourage you to also, you know, reach out to me if there's additional things that I can help support with. I have a lot of connections with different types of providers here at the University of Michigan. So again, as a non-clinician, there's some things I can't answer, but I certainly know somebody who can provide an answer from that clinical perspective.
Well, thank you so much for your time, Dr. Mizik. It was great to hear from you. This was really, really helpful. This was really the first event around this that we've ever had. So just like Roberta just put in the chat, I'd like to see this be a more common topic addressed. So I'm glad that we were able to begin this discussion with you and learn so much from your experiences and research. So thank you again for being willing to share with the collaborative.
Of course, I look forward to it. Happy to come back if that would be helpful. Thanks so much, everybody.
Yep, thanks. We'll get the slides sent out to everybody. We'll have the recording of the talk posted, and the sign-in link is in the chat, and we'll send it to you afterwards as well. Thank you again all for being here. Thank you, Dr. Mizik, for the presentation, and hope everyone has a wonderful weekend.
Thank you.
All right,
I don't,
bye.
I don't know how to sign in. And I mean, I've seen just a minute ago, you put the address up, but I couldn't copy it. And I was on a phone call with the hospital with a patient who's failing.
I
trying to
will,
find-
I'll sign in for you, Dr. Carlton. I've
Oh,
got it
thank you
pulled up
much.
and I will do it for you right now.
Oh, thank you, John. I really appreciate it. Thank you.
No problem.
Take care.
Yep, you too. Yep, I will sign in for you as well, Molly. And Stephanie, it sounds like the training courses they're linked in the presentation that we'll send out from Dr. Mezek. So should be able to find those in the slides for you there. They're external, so we'll see. Yep, no problem, Molly, doing it right now.
Jackie, can you hear me?
Yes, I can.
This is Sally Prinz. I'm having technical difficulties and unable to put my name in the chat, but I have been attending as well.
Okay, I will take care of it.
Thank you.
Hello, Jackie.
Yep, hi.
It's Dr. Haber. Also, I had a rough time signing in, so I just want to make sure I am recognized that I'm in the group.
Absolutely, I will get you signed in.
Thanks.
Yep, no problem. Ashley, are you a physician?
Oh, Ashley.
Yeah, sorry. Dr. Haber, I got you. You're all signed in.
Okay, thanks.
Yep. Okay, I'm gonna go ahead and end the call. Thank you everyone again for joining. Really appreciate it. And we'll talk to you all shortly.